remind you is we are recording the session today, so please don't include any confidential patient health information during the session, particularly during discussions. You are on video, and there is information on how to turn that off if you need to, as well as muting your microphone. In order to receive CME or CEU certificates, we will need you to announce your name. You can do that verbally, or you can use the chat box, and I will send out a chat here shortly in order to allow you to see that. And there's a couple of new people who just showed up. That's great. All right, that's a repeat slide. Our disclosure and accreditation statements are on screen right now. We're required to display those for CME purposes. And at this point, let's go ahead and do roll call. Anybody who's out there who's on audio, we'd love to hear from you and join in on the discussion. And if you would, just let us know where you're from as well.
Hello.
Hello, we can hear you.
Hi, okay, good, thank you. This is Antoinette Kleiner. I'm calling in from Shiprock, New Mexico with Northern Navajo Medical Center.
Welcome.
Good morning.
And while we're waiting for others to announce themselves through the chat box here, why don't we go ahead and go around the room and introduce ourselves, with the exception of our speaker, of course. We'll have an introduction in a moment. So, Mary?
This is Mary Ramos. I'm a pediatrician here at the University of
Mexico. Policy Improvement Specialist here at Envision.
Elena Scher, Senior Statistician here at Envision, New Mexico.
And I'm Erin Marshall, and I'm with the New Mexico Breastfeeding Task Force.
Hi, and I'm Courtney McKinney. I'm the program manager for this initiative here at Envision, New Mexico. Do we have anyone else? Has everyone chatted in or announced themselves?
So anyone who hasn't announced themselves yet, please make sure that you let us know that you're out there through the chat box, or you also have an opportunity at the end to announce yourself.
Good morning.
Good morning.
Monica Toquinto, and I'm representing Nuestra Salud.
Good morning, Monica.
Good morning.
Good morning.
Good morning.
Philippa Howard. Melinda Rogers.
Okay.
So far, I'm sure we'll have more jumping in as we go, and I'll keep track of that.
Okay, let's go ahead and get started. Before I let Erin Marshall introduce Dr. King, I just wanted to let everyone know that at the end of this presentation, we're going to have a satisfaction survey available for you guys. So if you could just please fill it out, it really helps us think about how we can improve these sessions for you guys to make sure that we give you the most up-to-date, current, and accurate information. So please fill it out if you have some time. And a special request from Dr. King. So as he's going through his presentation, if you guys have any questions, discussion points, or any thoughts that you'd like to share, please jump in and feel free to interrupt the presentation as we go along. All right, so I'll pass it off to Erin.
Great, thank you. So good morning, everyone. Nice to see so many familiar faces and names. I just want to welcome you. This is the first of a series of these telehealth sessions that we're doing. This is part of our partnership under Envision New Mexico that also includes Nuestra Salud. So I just wanted to acknowledge Monica. I'm glad to see that you're joining us today from Nuestra Salud. Thank you. We're really pleased to have Dr. King here with us today. He's here doing a number of presentations, and we're glad that he made time to join us today for this series. Gerald King is a professor of pediatrics and the director of education and outreach for the Division of Neonatology at the University of Utah. And during his career, he has served as the medical director for the University NICU for 20 years and as chairman of the American Academy of Pediatrics District. Oh, you're testing my Roman numerals here. 8. Let's see, that's a section of neonatal perinatal medicine, Western U.S. and Canada. He's currently the AAP Utah chapter breastfeeding coordinator and task force leader in developing a mother's milk bank in Utah. So we're really pleased to have him here. Thank you, Dr. King.
Nice to be here. Thank you. And I was serious about asking questions. If you have any, just interrupt. I'm glad to answer them at that time. So I have nothing to disclose. I am the chairman of the board of a developing milk bank, which is a nonprofit and is not yet a commercial entity. I have nothing against cows or formula companies. Even though I may have a few harsh words for formula, I'm really trying to promote breastfeeding and human milk use. The American Academy of Pediatrics section on breastfeeding issues policy statements periodically. The most recent was in 2012. And I got a few quotes from that article just to let you know how they feel about the subject. Breastfeeding has always been held up as kind of the best thing for babies. But in practice, most babies are not breastfed for very long. And the American Academy recommends that it be exclusive for the first 6 months of life. And we'll show some statistics later that show just how well we're not keeping up with that recommendation. They also made the point of saying that based on evidence-based studies, that there are risks of not breastfeeding. And people don't tend to think of it in those terms. They think of not being immunized as creating risk for the patient, but not breastfeeding doing the same. They also make the point that infant feeding should not be considered as a lifestyle choice, but rather as a basic health issue. And while it ends up being the choice of the mother or the family, and there are many lifestyle issues that impact whether they're able to continue breastfeeding, it is a basic health issue in terms of its benefit to the baby. So when a mother says, I'm not going to immunize my baby, a red flag tends to go up, and we want to sit down with that person and discuss the pros and cons of that decision in hopes that they may be persuaded to go ahead and immunize their baby. When the mom says, I'm not going to breastfeed my baby, the reaction is typically not so strong. So is it okay or not okay? These are the statistics. The CDC provides these on an annual basis, and you can see how generally well we're doing with immunization rates and how generally poor we're doing with following the recommendation as illustrated in red. Exclusive for 6 months is what the American Academy of Pediatrics recommends, and it's backed up with a whole lot of literature that shows the benefit. But nationally, we're only about 20% continuing to breastfeed at 6 months of age. So why is human milk so important? I take care of extremely premature infants in the newborn ICU. They are the prime recipients these days of donor human milk because their moms often do not have sufficient for their needs through a whole extended hospital stay. But the near-term babies in the center picture and the term babies are really who the American Academy of Pediatrics is talking about, because those are the babies who can breastfeed. Why is it so important? Well, depending on how much breast milk a baby takes, like some with a formula supplement or exclusive human milk, and the duration, like in this slide, greater than 3 months or for a full 6 months, various benefits come to that baby statistically, and it really is very dependent on how much breast milk they consume and for how long. It extends over multiple organ systems. There's benefit for respiratory infections. There's benefit for gastrointestinal infections. And in the newborn ICU population, a dreaded disease called necrotizing enterocolitis, abbreviated NEC in this slide, is a pretty devastating illness for the babies with a fairly high incidence of death. And we have noted a decreased incidence by almost 80% with an exclusive human milk diet. And believe me, that is something that we want. And so the newborn ICUs of the world are flocking to this standard and trying to provide an exclusive human milk diet for their babies. But for the non-preemies, there are still even more benefits to be obtained. A 36% reduction in sudden infant death syndrome, independent of sleep position. So we lay babies on their backs because of the incidence is significantly less, but imagine more than a 33% decrease. And that's consistent over more than a dozen studies. Even though the exact mechanism is not understood, the association is very strong. The benefits for breastfeeding extend not just through the neonatal period and infancy, but into childhood and adulthood. So that if a baby was breastfed exclusively for these amounts of time, in this case just any, it provides a protection against some significant diseases. And it's interesting to note that these diseases are immune mediated. And I think that is the key, because those initial feedings create a bacterial population in the gut, which influences the development of the immune system to start with, to protect themselves so that they're not killed by the body's immune defenses, but eventually to also modulate the immune response. And that's probably also the mechanism for preventing necrotizing enterocolitis. Other immune-mediated infectious provoked onset, like type 1 diabetes, also is markedly reduced if that child was breastfed exclusively. And this is important because the incidence of type 1 diabetes just continues to climb in our society. Type 2 diabetes is practically an epidemic, in part because of so many overweight Americans, but also is immune mediated. And I think too bad that it takes 40 years to realize that that could have been prevented. And so there's a lot riding on whether the mom's decision to breastfeed or not, and for how long. This table summarizes the benefits, and you can see that if the mother breastfeeds but also supplements with formula, then virtually all of the benefits on the right column are not realized. And those are significant, including improved cognition and behavior. Still okay is my question. As we begin to appreciate these benefits, I'm not sure that every consecutive mother really realizes these statistics and how much of a risk she's imposing on her infant by choosing to not breastfeed. It is also, from a public health standpoint, a public health issue for cost, because when you prevent an infection, that saves a trip to the doctor's office or a hospitalization, which is very expensive, and somebody is paying for that. We either pay for it because we're the family, or we pay for it because we have insurance rates, which are based on how much sickness is out there. So by breastfeeding exclusively as a nation, if just 90% of us followed those AAP guidelines, billions of dollars would be saved, as well as lives, because some of these conditions are life-threatening. So how does donor human milk factor into this discussion? Well, breastfeeding is the gold standard, because with breastfeeding, there is a mother-child dyad, and they interact. The baby is part of the mother's microbiology environment. What bacteria she exposes her baby to, she also passes antibodies to that baby through the breast milk to protect the baby. And as her environment changes, so do the antibodies that cross into the breast milk. Then there's a nutritional aspect to this, where a baby who's hungry and wants more calories can feed longer and get more hind milk, which is higher fat content, higher caloric density. And if he does that, then the breast milk will begin to change, increasing the fat content of even the foremilk, so that the baby begins to get more calories. He can also adjust the content of the breast milk by wanting to feed more frequently, which translates to the breast that the baby wants more calories. So the composition of the breast milk is constantly adjusting to the individual growth and developmental needs of the baby. Expressed human milk, on the other hand, is just a point in time. There is no interaction with the baby. It's just expressed and saved for the baby to consume at a later date. So the cellular content of that breast milk is lost when it is frozen and stored for the baby to eat. Or in the case of the newborn ICU, when the mother brings it in for her baby to eat, it's just stacked in the fridge and thawed when needed. Donor human milk is expressed breast milk that is pasteurized. The pasteurization process ensures the safety as well as the freezing as it's stored and awaits its being used. But it's important to note that it is human milk in every way. Every single thing that's in human milk is also in donor human milk, even though it's pasteurized. The pasteurization process is as gentle as we can make it so that the bioactive components of the breast milk are not destroyed by the heat. And in fact, they are all preserved, though the activity of some is decreased. Because it comes from a human milk bank, pooling of donations from multiple mothers prior to pasteurization helps even out the differences. So some mothers will actually produce breast milk that it has a pretty low caloric density and others quite high. And it depends on how it's expressed as well. A commercial breast pump will bring out the milk, but if the mom combines hand expression, she will get more of the hind milk and increase the caloric content of the milk she's pumping for her baby. So, because of these benefits we've been talking about, the recommendation by the American Academy is to provide an all-human milk diet for preterm infants. So if the mom does not have sufficient, then donor human milk should be used, which means that every place that's taking care of a preemie, even if it's just a near-term baby, should have a supply of donor human milk to use. And they should specifically avoid using formulas unless there's a medical indication. That is part of the statement, and it's implied in this quote. Well, in the newborn ICU, the real driver for using donor human milk, other than the good recommendation of the American Academy, is the fact that it really does benefit the babies the same as mom's own milk. And the prime example is necrotizing enterocolitis. The incidence may be reduced by almost 80% if the preemies are fed an exclusive human milk diet. And because of that, most newborn ICUs, and I say most because there's still a few doctors around who are not so enlightened and aren't believers, you might say, but at the University of New Mexico they use it, at the University of Utah they use it. But it's so much in demand that it's almost necessary to ration it to all the babies in the nursery. So generally, those less than 32 weeks and less than 1,500 grams are receiving it. In our nursery, because of the decreased incidence of NEC, we've extended our limit to 1,800 grams in 34 weeks. Another large urban hospital I work at with thousands of deliveries also opens it up for any baby in the first week of life because of how critical it is in the transition of the GI tract after birth, because that's when they're establishing the microflora, which will benefit the baby lifelong. And there's a window of opportunity because eventually the baby's stomach acid levels are going to reach adult levels, and bacteria that they swallow will be killed, and the potential to establish a microflora will be compromised. So it's important that all babies get it at least during the first week of life, and all preemies should get it at least when they're at highest risk for necrotizing enterocolitis. But ideally, all babies should receive it all of the time. This is just additional data about necrotizing enterocolitis from a Cochrane review, which is quite an authoritative source. And it consistently shows that feeding with donor milk or mom's own milk help prevent necrotizing enterocolitis much better than formula. These are the statistics at the University of Utah. in 2010, the Vermont-Oxford network required submission of data by gestational age. So the 23 to 29 week incidence of NEC is portrayed here was probably much higher than the unit average all along, which is in orange. But you can see with the introduction of donor milk in 2010 that the rate has fallen steadily, and it would have fallen more acutely if every practitioner had used it. But it's taken a while to convince people. People are skeptical about so-called new therapies, even though we've been breastfeeding babies for a long time. Does an exclusive human milk diet make a difference? This is a study where 70% of the baby's intake was breast milk. And the study was about what they were supplemented with if mom did not have sufficient to provide 100%. So some babies received human milk as donor milk and a human milk fortifier. And the other babies received formula or a bovine human milk fortifier. And this is the study that showed almost an 80% decrease in NEC with the all-human milk diet. This is a different study where they compared formula-fed babies to exclusive donor human milk-fed babies, just so you see that donor milk is actually behaving as well as if the baby had been fed mom's own milk. And you can see the huge difference in the incidence of NEC and whether they were severe enough to need surgery. Most units report their NEC incidence to Vermont-Oxford as a single number. They don't differentiate what kind of feedings the babies had received. So our unit, if you go back, the incidence was around 11%, same as Vermont-Oxford network. And for all intents and purposes, we were doing as well as the average hospital in the Vermont-Oxford network. So what's the impetus to do better, other than the fact that we'd like to prevent all complications? Well, if we had divided our population into them that received all donor milk versus formula, we would have seen an even greater decline in the incidence of NEC in our unit. And that's something that is just slowly dawning on every practitioner now, and the demand for donor milk just keeps going up. But the benefits are not limited to infectious problems, as reviewed before. There's also a potential for improved cognition or intelligence, their IQ. And this tracks several measurements and basically shows that as the baby receives up to an exclusive human milk diet, their outcome continues to march up and improve at every point, to where it almost seems like a dose-dependent effect. The more human milk you can get into that baby, the better the outcome. So that particular study was repeated at 30 months of age, because developmental follow-up is important to get follow-up over time. Initially, you can be a little fooled, but eventually you will not. So at 30 months of age, the differences not only persisted, but increased, comparing the human milk population to the formula population. So at the University of Utah, these are our statistics. The top line is moms who want to breastfeed, and the babies receive some breast milk from their mom. And the bottom line is those who are able to provide an exclusive human milk diet for their babies. So historically, we have come from the mid-teens up to the mid-20s in 2010, and that's when we introduced donor human milk. And it's interesting, even though we later weaned the babies off the donor human milk at a certain gestational age and weight and put them back on or onto formula, the rates of both breastfeeding and exclusive human milk diets continued to rise, because word was getting around in the unit that this was important for the health of their preemie. And so more moms tried, a whole bump of 10%. So we're now over 90% want to breastfeed, and another 10% in those who are able to do it successfully for the whole hospital stay. So there is value to not only using the product for the patient, but also for the mothers who are watching. And we take care of a lot of multiple gestation pregnancies. So those moms are very challenged to provide enough milk for their twins or triplets. And the donor human milk really makes a difference for them. This is a follow-up study finally out to 6.5 years. So this is after they've started school. The testing is very accurate. And you can see that verbal IQ, performance IQ, increases depending on the duration of an exclusive human milk diet. Problem in the newborn ICU is that we do ration donor milk. And so basically, all of the ones whose moms didn't provide sufficient get transitioned to formula before discharge and effectively dumped in the lowest outcome group. And that seems ironic in a place dedicated to optimizing the health care of their patients. In fact, that's what we do generally in medicine. What do we do that increases the risk to our patients? Nothing. We avoid it like the plague. Yet we transition babies to formula knowing that this is going to happen. So reiterate the policy of the American Academy. There are risks to not breastfeeding. If you look at that benefits chart and just reverse the statistics, if everybody was breastfed and the moms occasionally chose to formula feed, these are the statistics that they're subjecting their infant to. And I think that that would make a difference in their thinking if we educated them. So if any increase in risk is unacceptable, the question is, which are you? The one that sees it or the one that doesn't? Hopefully, we're the ones that do. Because even though we believe breastfeeding is important, this is actually what happens in the hospital. When the baby's hypoglycemic, we feed them formula because mom's milk is not yet available. We could just as easily thaw some donor milk. It takes 5 minutes. Mm-hmm. If that baby is ready to eat and he's rooting around and mom is, say, too sick to be there for the feeding, or her milk is not in and we know that they're not going to get much of a feeding, then we often supplement with formula until mom's milk comes in. Or if we've got an IDM stuck in the nursery on an IV and his mom's milk is not in, what do? We give them formula and advance them to wean them from the IV faster. Or if the nurse tells us that she's about to run out of breast milk that the mom has brought in, what do you want to feed the baby? We say, well, just give them formula. We don't bat an eye. We just do it. Or in our own hospitals, because there is a limited resource there, we transition babies to formula. So what message does this behavior send to their moms? Well, what it says is formula is okay. But why? Because the doctor ordered it. The doctor said it was okay. And that message sinks in. Because someday she's going to decide, am I going to put up with the difficulty of breastfeeding? Or when I go back to work, am I really going to be pumping and trying to keep it going? Mm-hmm. And the doctor has said multiple times, multiple ways, formula is okay. That is the clear message to mothers. So let me give you all a quiz just to see how affected you are by this information. If a mother says, I'm not going to breastfeed, and you are of a mind that formula is a reasonable alternative, then typically what you would say to that mom is, human milk is best, but formula is okay. And you would continue to supplement that baby with formula whenever needed. If instead you thought, after reviewing the data, that formula really isn't a reasonable alternative, and the mom says, I'm not going to breastfeed, well, then the red flag goes up just like with not immunizing. You spend a little time with that mom and explain the risks and benefits, and you really do try to persuade her a little to change her mind and breastfeed the baby. And you are well along your way to establishing a baby-friendly practice. Well, would anybody be so extreme as to say to that mom, well, formula really shouldn't be used unless medically indicated? Well, that isn't so extreme, because that is exactly quoted from the American Academy of Pediatrics statement on breastfeeding and human milk. That is where they're coming from. And some nurseries even go to the point of, instead of consenting the mom to use donor milk, which is not necessary, they require an assent document to use formula. And they think of that orange slide with the table of risks. Say, if you feed your baby formula, these are the risks. But if you feel okay about that, just sign right here and we'll feed your baby formula. And those people are well on their way to being actually human milk advocates. And they will be beating up the legislature to provide some place for a breastfeeding mom to pump at work that's reasonable, someplace besides the restroom. They will give her a little break to allow her to do that, because it improves the health of the community, not just her baby. Well, there's a lot of reasons why this is difficult to achieve, in addition to our own attitudes. One of them is that breastfeeding concerns are very prevalent. These are the concerns. And the minute a mom begins thinking along these lines, she is going to consider stopping breastfeeding and just putting her baby on formula. So whether she does or not depends not just on having these concerns, which are very common. I mean, almost every mom has a concern, and it doesn't go away in the first few days. It may persist for several weeks before the baby finally is doing well with breastfeeding. So if they have these concerns and they're unresolved, this is the frequency of stopping human milk feedings and going to formula. And you can see how much less often that happens if the concerns can be resolved. And the time to do it is in the first week. And typically, that mom has a shortened hospital stay because the insurance company is pushing her out the door. And she goes home, and the lactation support at the hospital says, please don't call us because we don't have a mechanism to provide this counseling once you leave the hospital. And the average mom doesn't even know what lactation support is available in the community. And if she goes to her OB or her pediatrician, they don't have anybody in their clinic that provides lactation help. And frankly, they don't have an hour and a half to spend with the mom and work through the issue in their office, even though there are billing codes where they can bill for their time, but typically they've got too many patients to see. And so they just don't take the time and they don't make the referral. And that's why our incidence drops from 80% to 20% breastfeeding over the first 6 months. Moms ultimately turn to formula, and they have consistently received the message that it is okay. So in the newborn ICU at the University of Utah, question.
We do have a question that came in along with a potential answer. What is the cost difference to hospitals between formula purchase or donor milk purchase? This could also explain why hospitals prefer formula over donor milk if it is cheaper and more accessible than donor milk. And
yes, well,
one person who answered about $4 an ounce for donor milk.
Yes, thank you very much. That's the answer. It is really too expensive to use for an outpatient where insurance is not going to be paying for it. Hence the focus on inpatients. And for other reasons, they desperately need it. But formula companies are billion-dollar companies. They give hospitals the formula. They give the little take-home bags. They call you up in 6 weeks. Are you going back to work? Here's another bag. They go to their pediatrician, try this formula. You know, it's just set up to pull people away from breastfeeding to formula. If you look at this slide, the nurses in our NICU had finally had enough of this behavior. And over their dead bodies, were they going to give formula to the baby for the first feeding? So they they threw all the neonatologists to the floor, twisted their arms behind them, and insisted that we use human milk for the first feeding. That's all they asked, the first feeding. And we did it. And that is when things started to improve, because moms, for the first time in our unit, got the clear message that it is very important to your baby that we give them human milk. And that's where we're starting. And so even the moms that were not destined to breastfeed, we asked for colostrum during those first days, and we gave it to their babies. And once they realized that the attitude of the doctors was really that this is important for the health of their baby, that's all mothers care about anyway, and they began trying to breastfeed with greater frequency, succeeding in breastfeeding with greater frequency. And that's just one thing that we did in our nursery to improve the situation. So aside from all these things we've already talked about, how hard is it to provide an exclusive human milk diet? And this will get to the question that was asked. The main obstacle for people is cost. So this is something we would portray to hospital administrators who are buying it instead of using free formula. At $4 an ounce, this is what it actually costs to feed a population of babies less than 32 weeks or 1,500 grams at birth. So that typically plays out in different scenarios. There's the group of moms who want to breastfeed and have sufficient breast milk. And very little donor milk was used in those cases, and generally just as a bridge until mom's milk came in. And that added up to a whopping total of $27. More often, the moms didn't have sufficient breast milk and needed to supplement with something. So they were supplemented with donor milk and used up to 45 ounces on average. Again, for not a very high cost. Even at $4 an ounce. In a hospital, these look like the cheapest thing that the patient is being billed for. Those who stopped pumping at some point because they just gave it up, they were too frustrated, or they went back to work and had already made that decision, they used a lot more donor milk, but it still didn't add up to a whole lot of money. And the preemies who had nothing but donor milk from start to finish here added up to $590. On average, it was just over $200 per infant per hospital stay. And not a big ticket, even taking all these 46 infants cost lumped together. $10,000 is not much in a multi-billion-dollar hospital budget. And it's not much compared to what else we do in the newborn ICU. These are actual figures from 2 hospitals that I work at, what they charge the patient, what they cost for themselves to provide the service. So either way you look at it, how many babies get through their hospital stay without getting an abdominal film and a CBC because of a feeding intolerance? Yet babies on an exclusive human milk diet progress to full feedings faster, have fewer feeding intolerances, and go home sooner just because of the diet that we choose for them. And with the TPN costs alone, as is illustrated in that article reference, if you shave 7 days of TPN off of every baby's hospital stay because you're giving them an all-human milk diet, you've already paid for their human milk many, many times over. So cost really shouldn't be an issue. You just have to convince the hospital administrator that this is cost effective. Even more so if you consider how many babies will get necrotizing enterocolitis who are formula fed. That is a very expensive disease as well as a very devastating disease. And you can save almost $10,000 per infant admitted by giving donor human milk to the ones where NEC can be prevented. So here we are, we're talking to the mom and she announces, I'm not going to breastfeed. She has had most of 9 months to contemplate this decision. So obviously there's a lot that our OB colleagues can do to counsel and work with this mom to educate her on the benefits and risks and to help her to make the right decision, at least to try, so that the pediatrician is not confronted with moms who are not even prepared to do it. So what can the obstetrician do? they can do all the things that are listed here. And it's not just for the baby's benefit, but the mothers also benefit from breastfeeding. In this particular study, breastfeeding could account for almost 2/3 of the estimated reduction in breast cancer incidence. And it goes on. The benefits that we described in childhood and in adulthood, if the infant was breastfed, apply to that mother as well. If we could just kind of get the cycle going so that every successive generation had a higher incidence of breastfeeding. Postnatally, there's a lot that we can do in the office as well. And I think the important thing is to develop a little passion for this, because it is as important to that baby's health as immunizations. Establishing a baby-friendly practice is something that can happen in an office and not just in a hospital setting. And really, it's what we do. We teach moms, we help moms, we show moms. That is what we do in the office. We give them anticipatory guidance and teach them about all kinds of things, generally around preventative care. We just need to spend a little more time doing that with breastfeeding specifically, because that is a silver bullet that we haven't put into the gun yet. That can really do more for that baby's health than any other thing that we can teach that mom to do. So that boils down to having a written breastfeeding policy. And how does that work? Well, when all these circumstances happen, which happen every day in any hospital, our policy instructs that nurse what to do before they call us, or informs them what we're going to do when they call us. And basically, we're telling them to do everything possible to avoid formula and to use donor milk if the mom's milk is not sufficient or there's an urgent need for something, like in hypoglycemic infants. That sends the right message to all of our moms. And that is what the healthcare provider needs to do. The other problem is that, as illustrated in prior slides, breastfeeding, though natural, is also a learned skill, and there's many obstacles that these moms face before it's actually working well. Yet, if you ask the mom, how is it going? Almost all of them will say, it's working great. Yet, if you observed it, you would note that that baby is not sucking and swallowing audibly. He's not really transferring milk. He's just sort of sucking on the breast. Even though he's latched, breastfeeding still isn't effective. And that's the main reason why babies come back with bilirubins over 20 on day 2, 3, 4, is because of ineffective breastfeeding, which we need to get better at figuring out and educating the moms so that they know as well when it's actually working. So these are multiple sources of information for us as practitioners. We send our pediatric residents to the AAP website. They read about breastfeeding. They can take quizzes, and they can receive a printed certificate saying they've completed the curriculum. And every practicing physician could do the same thing. There are other hotlines and means of support. And the the Academy of Breastfeeding Medicine provides protocols for all of these problems, so that you don't even have to spend the time to study. You can just go to a website and pull off the protocol, and they'll tell you exactly what to do to promote breastfeeding despite problems that are occurring. It's also important, as you can imagine, to have a real expert somewhere in the community, preferably in the hospital and in your clinic, that can work with those moms and help them. So we're getting short on time. I'd like to leave time for questions. Let me run through these last slides a little faster. And if you want to break in and ask a question at any time, please do so.
And we do have one that just came in.
Okay.
Is the risk of using formula related to the duration of use?
No, using formula at all loses all of those benefits of breastfeeding right from the start. So that baby will experience more infections in the first 2 months of life. as well as other risks. The duration of breastfeeding is what brings the benefits, but formula is an all or nothing thing. So is there enough donor milk for those who need it? The answer is no. Demand is currently exceeding supply. How does a milk bank increase the supply? It improves community education and promotes breastfeeding, and it establishes donation sites for moms to donate excess milk. And that in itself educates the community because people become aware of moms who are donating. So we encourage hospitals to establish donation sites so that they can donate at least what they're using. But in practice, the donation sites need to be in clinics as well, because that's really where the patients frequent, and they don't want to hassle a parking space at the hospital when they can go to their neighborhood clinic and drop off the milk much more conveniently. The safety and quality of different donor milks that are provided does differ. Safety is pretty much guaranteed, but the content is hard to figure out in the for-profit companies because they don't publish that information. The Human Milk Bank Association of North America is a collection of nonprofit milk banks. The one that services New Mexico is based in Denver, the Mother's Milk Bank there. It is always the lowest cost option, even at $4 an ounce. The costs range up to $9 an ounce or more from a for-profit company, and obviously somebody's benefiting there besides the moms and the babies. How might you help? Even in a clinic situation, even in a small town, you can establish donor sites at or near your local hospital or clinic. You can encourage women with excess milk to become donors. They can donate and send their milk in right from their house. They don't have to be within driving distance of a donation center. And you can ensure an all human milk diet for your patients, because that really sends the right message to moms and helps increase community breastfeeding rates. What is required for a donation site? You just need an administrator who's sympathetic to the cause. You need a very small freezer that can fit under a counter and cost less than $100. And you need a phlebotomist who can draw the labs on the mom. Typically, they just show up, say, I want to be a donor. They're given a phone number. They call and talk to somebody who talks about lifestyle as well as medications and diet. And if they pass that, they receive an application to fill out, which needs to be signed by their physician to corroborate the information. We're very careful about this milk. And then they have labs drawn, not unlike how a blood unit is screened for communicable diseases. And then in the end, it's pasteurized, which is destined to kill everything anyway. So it's very safe, and it's at no cost to the facility that's providing it as a collection site, other than a small charge for a freezer. So if there was one collection site in New Mexico, it would probably be in Albuquerque, but one site in a city of this size really doesn't get it done because moms are not going to drive across town. It's way too inconvenient. But there are many clinic sites, there are many hospitals, and if it looked more like that, there would be many more moms engaged in being donors. And it is in short supply. We really need that kind of assistance. How might each statement then resonate with your current healthcare facility? We are a baby-friendly hospital or practice. We are a milk donation site, and we provide an all-human milk diet for our newborn patients. This is a gold mine for public relations, and it also is a magnet for moms who are seeking these kinds of services and assistance to help them breastfeed their babies successfully. So breastfeeding is a basic health issue. This is not okay for babies. We need to do better. The physician who authored this statement in conclusion here is a female obstetrician. And you could put moms on a guilt trip in a hurry if you're too strident about the benefits of breastfeeding and she's not planning to do it. Because she still wants to do the best thing for her baby, but circumstances may be making it very difficult for her. But it is important that we are supporting the moms who are not breastfeeding as well as those who are able to do it, and trying to help them with all the support that we can provide so that if they want to do it, and even in New Mexico, almost 90% of moms want to do it. So the reasons for falling off we have reviewed, and we just need to play our role better as healthcare providers to support them. Any questions?
And feel free to unmute and go ahead and join the conversation, or I'll be monitoring the chat box. And one question, will the presentation be available for review after today? And we are planning on posting that on Moodle.
Yes.
As well as on our website video archive page. And Moodle is an asynchronous way to view it, take a quick quiz, and you can get half of a CME for that.
I have a question. And it's not known, but what are some of the proposed or hypothesized mechanisms between breastfeeding and protection against SIDS?
It's just listed as an association.
Okay.
It's like an observation.
Okay.
So the mechanism is not known.
No theories.
And in fact, if anybody knew why SIDS happens, that would help. But nobody knows the answer to that either. Sorry. The anticipation is killing me. You got to have some more questions.
What have you, I don't know if you know the answer to this question, but just thinking about the importance of advocacy and communication, what are some of the more effective advocacy strategies that you've come across, or communication around breastfeeding?
Well, I get a little of that from my association with the Human Milk Bank Association of North America, because in different states where they have milk banks, people are more or less engaged in advocacy. For example, I haven't heard anything good about Obamacare lately, but they do provide breast milk pumps. And that was legislated through the senator in Oregon who worked closely with the milk bank there. So if you're of a nature where you'd like to be an advocate and you don't mind talking to your legislator, there's just a long list of things that could benefit breastfeeding moms. Probably the most important thing is to have a place where they work where they can pump and store the milk until they can take it home, as opposed to fighting their employer that they really don't want to do. If instead the state government mandated that, then the employer would have to comply. And typically, if you have, say, maternity leave, you have to be a big company to be required to provide that. People with fewer than 25 or 50 employees don't have to follow those federal regulations. But that's where most moms work, is at the smaller places. So they're really not doing anything to help breastfeeding moms where it really counts.
So we actually have one of the stronger state laws around breastfeeding at work. But the issue that we face here in New Mexico is more about enforcement and compliance. But we do have the law in place. And actually we are approaching the 10th year anniversary of the establishment of that law.
Another example, in Utah, Medicaid will pay for donor milk for outpatients because of the value. But you have to qualify for Medicaid to get it. So that's good because it targets the lower income population who are most in need of something like that. It also helps the inpatients who have used it to discharge because of some medical condition like bowel disorder, where they need something optimal to keep things going. So you could lobby for Medicaid to approve payment for donor milk for outpatients. It'd be nice if they do it for inpatients also, because most insurers don't do anything that Medicaid doesn't require. Once Medicaid steps into the arena and starts paying for it, then there's pressure for other insurance to comply. And of course, hospitals don't get paid for every line item these days, so that may be lost in the payment plan. But at least it would, knowing that it's reimbursed, would help hospital administrators choose to provide it for their patients.
So we do have a question. When are we going to change our language? Oops, there it went up to another one. When are we going to change our language to emphasize the risks of not breastfeeding? By emphasizing the benefits of breastfeeding, we normalize formula feeding. We need to change our language.
Agreed. Really, it begins at the doctor's office, I think. If we use that language when we talk to moms, and we are talking to every single one of them from time to time as their babies move through their office visit schedule, or as the mom goes to see an obstetrician for her postpartum or antepartum visits, if we use that language and educate them when we have them as a captive audience, then they don't have to read it anywhere else. They will learn that from us. It helps with marketing and community awareness if people went to the expense of doing that. As a developing milk bank, we contacted the local billboard people and said, if you have an electronic ad space that's vacant because you don't have a consumer to pay for that, could you put this billboard in that advertises and educates the community about breastfeeding? So they agreed to that, and we had billboards up and down the state of Utah on I-15 that flashed up for 10 seconds, just like the rotation that people see, and it was no charge to us to do that because they donated it. So there's another thing that you could do for all of the sign companies in town, because that's unused space otherwise.
Question for you. Do you have more here?
I have one more.
Go ahead.
Okay.
Nope, go ahead.
From Elsa, some of our breastfeeding peer counselors have reported moms' concern about purchasing donor milk from Colorado due to Colorado's legalization of marijuana. Have any of you also heard of this?
Yeah, Denver is at the epicenter of that issue because of what their state has done. And it's definitely not okay to breastfeed if you're using marijuana or to donate it. So obviously that's a question that people ask. And it is, I mean, it can be tested, but it's impractical to test 100 donors when one may be a problem. It is affected by pasteurization, and it's also pooled with multiple donors. So typically the amount that would, say, pass through the mom's own breast milk to her baby would be much smaller. And if she donated that breast milk and it was diluted with multiple other people, then it wouldn't be at a significant level where it would harm the baby anyway. But the people at the milk bank are working overtime to make sure that nobody is donating with that in their history. And that pretty much comes out in the history. I think donor moms as a population are, they are really motivated to do something good for another person. And they exclude themselves once they learn what are the reasons to be excluded. So a lot of moms are taking ordinary medications, and some of those would exclude them as a donor. And they find out about that in the interview process. So I really don't think anybody has anything to worry about with marijuana getting into the donor milk pool, because it is looked for very intensively.
Dr. King,
Sorry,
got one more?
Sorry. Just came in. I thought there was insufficient long-term data on marijuana exposure through breastfeeding to determine whether the risks outweigh benefits.
The risks of some exposure to marijuana do not outweigh the benefits of an exclusive human milk diet. But we do everything we can in the healthcare system to get moms who are breastfeeding to not use marijuana and other harmful substances. And that's about all that any of us can do for now.
And if I can say, we also, again, this is a one in a series of these sessions we'll be doing. We do have an expert on substance use and breastfeeding who will be doing a later session for us. We'll take a deeper dive into some of those issues. So I realize this kind of came up at the end of this program. So to let people know we will come back and address those issues.
And if you want to read a little bit more today, you can go to the website for the Mother's Milk Bank in Denver, and they'll have some information about marijuana use.
So, great. Well, if we don't have any more questions, thank you so much, Dr. King. This has been absolutely fabulous. And we do hope that everybody will join us again on December 7th at 3:30 for our next session, which will be with Drs. Emily Sebesta and Sophie Peterson presenting implementation of the 10 steps to successful breastfeeding from the OB and pediatric perspective. So thank you again. We look forward to seeing you all again.
And I did just post our brief satisfaction survey link on the chat box. We'll also be blasting that out on email to everybody who signed up for the session. And if you wouldn't mind taking a second to fill that out, it does help us improve the experience. So thanks again.
Okay.